Welcome to today's clinical epidemiology session. Dr. Anna Paul, Associate Professor, is going to take us through critical appraisal of health technology assessment. Just to put it in perspective, 3 weeks ago, we did accuracy studies, sensitivity, specificity, likelihood ratios. The following week, we did critical appraisal of a diagnostic systematic review, which is a little step up from doing a single diagnostic study, combining many studies together as a systematic review. So we had covered diagnostic systematic review. If the new test is a continuous test, then we had to do an ROC curve. So last week's critical appraisal was a diagnostic test which had used ROC curve, and Dr. Anuka had taken us through how to critically appraise a paper where ROC is the main focus. Today we're taking one step forward. So Anna is going to teach us about, suppose there's a new test or any new technology. If you want to use it in the hospital setting or an institution or a state or a country, how to do that. It may sound like a high-tech thing for only high-income countries, but actually, in fact, if you have less money, you have to be very careful how you spend it. So actually, for low and middle-income countries, ensuring that new tech is equitable and efficient and high quality is more important than even a high-income country. It could be any device of any sort. A new medicine also could be called a technology. It could be an implantable device. It could be a non-implantable device. So all of these come under the health technology assessment. Just one last word before I hand over to Anna. WHO classifies this as 3 types. Health technology regulation is the government giving permission for the tech to be used in the country. That is more focused on safety. So if the tech is not safe, they won't allow it to happen. So that is health technology regulation, which is mostly about the safety of the device. What Anna is going to talk today is health technology assessment. Is a device efficacious, cost effective, and stuff like that? WHO puts a third part called health technology management, which is about procurement, training of the doctors, alternative technology, and how to implement it locally in a particular place. That everybody who listens to today's talk and wants to implement the tech in their own place will use that part. Some of it is also covered under health technology management, but just to say that some people divide it into health technology regulation for safety and getting it into the country or a place, health technology assessment, which is today's focus, and health technology management, which is about actually using it in real life in your own local situation. So with that little bit of introduction, I'll hand over to Anna.
Thank you, sir. Okay, so sir has already given sort of an overview of what health technology assessment is. So today I'll be critically appraising a health technology assessment. So what is a health technology assessment? So sir has sort of covered a lot of it, but it's a systematic evidence-based evaluation of a health technology to guide clinic practice and clinical decision. So it covers multiple domains. So far we've looked at systematic review is top of the pyramid. We've done cost-effective analysis. We have a diagnostic study. Now, what a health technology assessment does is it compiles all of that together. So it covers efficacy, is it safe? It looks at cost. It looks at patient societal perspective, legal perspective. So it's like an all-encompassing document. So, but what counts as a health technology? So almost everything counts. So medicine can be a health technology, medical devices, diagnostic tests, vaccine, a procedure, a public health program. All of this fall under a blanket of a health technology. Now, why do we need health technology? So healthcare budgets are limited. Resources we need to allocate it to where higher value intervention. So where should we be sending this money? And it helps to especially for an insurance perspective. So who gets reimbursement? What should be reimbursed depending on the healthcare system? So who uses HTAs? So it can be a government, can be a large hospital or health networks. It can be the insurance providers and policy makers. So some questions like a HTA could answer. Should a hospital adopt an AI-assisted chest X-ray reading for TB? Should a new cancer drug be reimbursed? So should a screening program be expanded? So these are some questions that a HTA will address. So now types of HTAs, you can have a full HTA. So it's a comprehensive, in-depth, it covers all the domains that I will be going through subsequently. It takes a longer period of time, understandably. Then you can have a rapid HTA, which is a more restricted thing, which does not cover all the domains. So it won't cover patient, legal, societal, all those aspects are not there. But the cost and effectiveness alone is covered by rapid HTAs. And so obviously it is much faster to come out. Then you have something called a living HTA. So that means it's ongoing. So it's constantly open. So as new evidence comes, say for example, like if you the COVID vaccine, so it was so dynamic, it kept changing during that period of time. So each time to repeat the entire HTA would be too labor intensive. So that means you just keep updating it as and when new information comes. Then you have something called the adaptive HTA, which is what WHO strongly recommends for low and middle income countries, which means you take an existing HTA and then you adapt it for your situation. Then you have something called a mini HTA, which is like a small HTA which can be run by a hospital. So that sort of tends to focus on organizational budget and safety issues. A mini HTA is also called a hospital-based HTA. So now, like always, we'll start off with a case scenario. So ICMR TB survey, the 2019-2021, they did IGRA on a small subset of participants, of which 21.6% were positive. So almost like a third of patients have latent TB is what they concluded. Now, should CMC as an institute start screening patients for latent TB? And should we start using IGRA for the people we are considering is a question. So now for that, I'm going to look at this Ontario Health Technology Assessment Series. They've looked at IGRA for latent TB infection from a health technology assessment. So this is the article that I'm going to be appraising today. So now how to appraise a HTA? So the thing is, so far we've looked at, CASP questionnaire, quadas. We have these tools which have very well-defined questions. So Section A, Section B, Section 3, each question and what to look for. Unfortunately, for a health HTA, there's nothing as defined as that. So what we have are some tools which overall look at how a HTA should be done. How should the HTA, what are the domains that a person doing a HTA should look at. So I've used that to sort of create a tool. So the one I'm mostly going to be using is this European Network Score HTA model. So the things that they look at is, so for example, for a rapid HTA, you would need to use, what is the current use of this technology? What are the technical aspects? Are there any safety concerns? And then you do the clinical effectiveness. Then the next step which we don't usually do is cost and economic, ethical analysis, organizational, patient social, and legal aspects. Okay. So now we'll be covering all these domains in the next few slides. Now, WHO has also brought out a manual which is looking at health technology assessment of medical devices. So it doesn't cover like domains, or it's not a questionnaire kind of thing, but it covers what all a health technology assessment should be looking at. It sort of explains what each of these domains are. So I've sort of combined the two, and that's what I'll be going through. So the first domain is health problem and priority setting. So any HTA that's being done, you need to decide, is it a priority? So, and to decide whether a problem is a priority, you look at burden of disease, public health importance, and unmet need. So now this is actually published by Ontario, that is in Canada. So this is from a Canadian perspective. So their burden of disease, latent TB affects around 25% of the people. A lot of immigrants. So the most active TB cases in Ontario are from reactivation of latent TB. So for them, they feel it's important to screen and treat the latent TB patient, especially among the migrants who tend to be, those who are coming from high burden places will have BCG, been given BCG, which affects your tuberculin skin test. So therefore, they feel that an IGRA might be a better test. As of now, it is out of pocket. So if you want to do an IGRA, you have to pay out of your pocket. It's not publicly funded. And the population that truly need this test are the immigrants, immunocompromised. They are the people who might not be able to afford the cost or the multiple visits for a TST. So therefore, they feel that IGRA would be a better test, and therefore they've done this health technology assessment. So domain 2 is description of the technology. So I'm not going to go into the details because we sort of know what TST and IGRA is, but they actually describe how a TST is done. They actually describe how an IGRA is done. So IGRA in Canada, they have two IGRA machines. So the Quantiferon TB Gold and T-Spot are the two that they have. So they've mentioned what the technical requirements will be. It's a single blood test. It has an incubation period. It needs an automated machine. And as of now, it's not publicly funded. Only few laboratories, central nodal laboratories have it. The current test that they're using is the tuberculin skin test. Problem with it, it requires two visits, placement visit, and they have to come back. It needs technical skill to read it. And if it's affected by immune status, BCG vaccine status, all of these can affect it. So they describe the technology. Then comes your clinical effectiveness. So how does it work? So since it's a diagnostic test, you want to look at your sensitivity, specificity. So what they have done for this domain and what you have to do in a HTA is do a systematic review, meta-analysis, or a systematic review. So that means, like we've already covered, they've done a wide multiple database search. They've specified their time period. In the interest of time, I'm not going to go through each of those domains, but they have to do risk of bias. That entire thing needs to be done. So they have searched for multiple databases and they've looked for systematic reviews. So they have not looked at individual RCTs. They've looked for systematic reviews of diagnostic accuracy studies, which we covered 2 weeks ago. So looking at sensitivity and specificity. So their population were adults greater than 18 or children 2 to 17. And the population had to be their target group. So either it was immunocompromised, migrants, or TB contacts. The intervention was IGRA or a TST followed by IGRA, IGRA followed by TST. Comparator was TST. And the outcomes they were interested in was diagnostic accuracy, sensitivity, specificity, predictive values, and clinical utility. So they looked at progression to active TB. And they also wanted to see if there were any indirect measures of clinical utility. So like how many diagnostic tests or impact on decision making. So that was what their, it's sort of like the PICO of this domain that they looked at. So they identified, this is a Prisma. They found around 764 articles. Through Gray literature, 17 articles. After removing duplicates, they had 467. Full text eligible were 121. Of these, they were excluded if they had wrong patient population, wrong intervention, outcome of interest not reported, or if it was not a systematic review, just a narrative review. Finally, they had 49 articles. Now, they wanted only articles published after 2020, which they had pre-specified. So finally, they had 12 articles that were included in this systematic review. So they, like in all systematic reviews, they give you the study characteristics. So the year it was done, the review method, the population, which test was done, the number of patients, and they've also given a quality assessment. So they've done the QUADAS 2 like we went through 2 weeks ago. So they've given it for all the studies. I've just put the first part of the table. So then they give you the results. So the results is sensitivity and specificity of IGRA. So each study, what their pool sensitivity and pool specificity was. Now, just want to highlight that overall, if you look at it, the specificities were, apart from this study, most of it had higher specificity. Sensitivities were a little bit more variable. But on an average, the pool specificity was greater than 90 for a lot of them. They also looked at disease progression. So here what they've looked at is with IGRA, there was a higher chance of IGRA being positive. That patient was more likely to then go on to develop active TB. And that was similar across each of the studies and in the different subgroups. Okay, as compared to the TST. So overall, IGRA in terms of clinical efficacy had a better sensitivity specificity and was better able to predict those who go on to develop active TB. What they didn't do was they didn't do a meta-analysis. So they've just synthesized all the systematic reviews results. They have not pooled it all together. They don't give you a grade of evidence. And WHO does not require a HTA to do this. It's okay to just give a synthesis. A systematic review is enough. They don't have to do a meta-analysis. The next domain was safety. So they have not addressed the safety issue at all. As such, when you think about it, like this is my point. So like what are potential safety concerns with a tuberculin skin test or IGRA? So one, maybe you can have a local reaction. What happens if there's incorrect reading because there's a human aspect to reading the TST? IGRA, you can have an indeterminate result. So what did they do for that? Those are things that they could have thought about, but they don't specifically cover this in the safety domain. Now comes an important domain, which is the economic evaluation. So in economic evaluation, you have cost effectiveness, then you have to look at the budget impact, and then you need to do something called uncertainty analysis, right? Because all of this economic is modeling studies. So then there's an element of uncertainty. So if each factor changes, that might change the result. So this was only partially done, and I'll come to why. So when you did the cost-effective analysis, this again, they've done a systematic review. So they have looked through all databases in the given time frame, looking for articles that have done a cost-effectiveness analysis for IGRA. For this, they looked at only English studies, and they had to be done in Canada. So they've only done Canadian studies and from a Canadian public payer perspective. So that was something that they wanted to. So if it was a general screening, only healthcare screening or non-health Canada approved tests, all of those were excluded. And the outcomes, the patient and the comparator was similar to the previous one. So that is adults, children in the population of interest. They looked at IGRA versus TST. The outcomes here were, the health outcomes was TB cases prevented, and they've looked at quality. So now for quality, they from SF36, this is not what they have done. This is each of the studies have derived their own utility scores. So for latent TB, they've given a utility score. For active TB, they've given a utility score. And the utility decrement based on if they had hepatotoxicity, if they had hospitalization, then the utility would come down. The economic outcomes, they looked at per person total cost, the screening cost, diagnostic workup cost, and they've also looked at the incremental cost effectiveness ratio. I'll come to what the ICER is later. And the time horizon they looked at is over 5 to 25 years, so that you can capture the future TB cases, long-term medical costs were looked at. So again, this is their Prisma. So they've identified 718 articles through grey literature on 33. Record screens were 487, of which the full text 80 were excluded because if it was not done in Canada, if the study type, all of those things were excluded. So finally, they had only 5 studies that were included. So now they have provided these 5 studies as different tables. Now, this is an economic study. These are all model-based studies. So they give you the study characteristics. So what the study analyzed and the characteristics, the population, and what are the things that they varied in the model. So for each model, when you're doing a modeling study, we don't have all the data. So you need to change your sensitivity, specificity might change based on immunocompromised, BCG positive, BCG negative. How many, you're assuming the baseline risk of 22% latent TB, but if that changes, so you have to keep changing various parameters. So the things that you're inputting into the model is also described here. I've only put one of the results in the interest of space, but like this, they've given for each of the studies. And then they give you the results also as this table. So it's quite an extensive, like the cost and then the cost effectiveness for immigrants, for sequential testing, contact screening. So for the immigrant entry screening, the incremental cost range was around 16,000 to 35,000. So, but that's how they've provided this result. And they've given it for each separate study. What they don't do is they did not do their own economic evaluation. So they've just looked at pre-existing data and they've combined it and put it as a narrative synthesis. They couldn't pool the results together because each of these studies had a different time frame. So some looked at 5 years, some looked at 20 years, some looked at 25 years. The perspective might have been different. The population might have been different. One might have looked at only IGRA, one might have looked at TST plus IGRA. So And discounting meaning as the time changes, the value of the test and the value of it also comes down. So now all of these were different across each of the 5 studies. So they couldn't give you a pooled result. So therefore, this is just a narrative summary of the findings. So this is their, so they've just written it in text. I've just sort of summarized it. What their major findings was: IGRA reduced false positivity caused by BCG vaccination. Fewer unnecessary LTB treatment, therefore saved costs downstream. In moderate high TB incidence group, IGRA was cost saving. And sequential testing in that is TST followed by IGRA was cost saving when the prevalence was lower. Now, all this is just text. So I've just summarized what their 2-3 pages were. So now I just want to show you, this is another study. This is not this study. And this is actually a cost effectiveness analysis of a pragmatic screening strategy for latent TB in the European Union. So there, I want to highlight that they were looking at much broader thing. They were just not looking at IGRA alone. They were looking at the whole of latent TB management, but they have actually done it like they've done their own cost effectiveness analysis. They have multiple subgroups. So immigrants at entry, immigrants in the prison, all prisoners, homeless people, all risk groups, and they give you total QALY gained, the cost, and the ICER. So this is how ideally a health technology assessment should give its result for the cost effectiveness analysis. They've looked at healthcare perspective, societal perspective, and this is the table that they give. So a good HTA should actually give you this. So just briefly, this is mostly outside the scope of this topic, but just to tell you what ICER is, it's an incremental cost effectiveness ratio. So that means how much extra money do we pay for one extra unit of health benefit. So on top, you have cost of IGRA minus cost of TST. On the bottom, you have quality of life with IGRA minus quality of life with the TST. And you usually get a table like this. So this quadrant is more costly, more effective. This quadrant is less costly, but more effective. So you want your study to fall under this category. Here you have less costly, but also less effective. More costly, less effective. So 100% if a study falls under this, you don't want to do that. Now, the cost will depend on the willingness to pay. So different places will have a different threshold that they're willingness to pay. So that is this line. This line is the willingness to pay. So if it falls below this line, then you might want to implement it. So WHO broadly suggests a 3 times GDP per capita. For the European Union in this study, they have actually looked at 80,000 euros per QALY gained. India actually, based on our HTAs, what the average is around 1 to 3 lakhs, so around 1.5 lakhs per QALY gain is what India is on the recent HTA is willing to pay. So that is sort of how you look at it. So this is for the Netherlands. Netherlands is willing to pay 80,000. So if you look at for IGRA, it was like 24,000. So well within what the Netherlands was willing to pay for this. That's just how you would look at it. So the next step that was just for the cost efficacy of that test alone. But now you need to look at it from a budget impact point of view. So they have done a budget impact analysis. So cost effectiveness, is it good value for money? Budget impact is, can we afford it? What will happen to the budget if we are incorporating this into the study? So they have looked at a 5-year change in total health spending if Ontario were to publicly fund the IGRA test. So step 1 is identify population who would get the IGRA and the number of people in each group. So they wanted to look at immigrants, close contacts, and immunocompromised people. I've just put the table for the immigrant population. So they've looked at how many new immigrants will come over the next 5 years. They have assumed a prevalence of 22% for latent TB. So how many immigrants are at risk over the next 5 years? How many of them have already been vaccinated? So like that, they're giving you a number. So they've done this for each step. So close contacts, immunocompromised, all of that. Next, to determine what tests each group is going to receive. So are you going to do only IGRA? Are you going to do TST followed by IGRA? So that's for immigrants and contacts of TB. But for those who are immunocompromised, they also looked at TST first followed by IGRA, or IGRA first followed by TST. So the pathway that you're going to do is also needs to be looked at. Then you need to calculate per person cost of each test. So cost of TST. And in that, you have to include material, nurse time, visit time, cost of IGRA, the blood drawing, lab procedure, cost of the medical evaluation if a positive test comes back, cost of treatment. All this needs to be accounted for. So they've done that. So referral for TB, blood sampling, shipping, handling cost. They've looked at per visit for specialist, X-ray. Then they've looked at preventive TB treatment, post-treatment monitoring. So they have actually given the cost of each of these things. Now you need to combine all this. So all the tests plus the people, and then you calculate the score. So this is per person cost. Okay. So I just want to highlight here that so the current scenario is just a TST. New scenario is IGRA alone, or you can have TST plus IGRA. So now if you look here, the treatment for latent TB becomes cheaper as you include the TST plus IGRA. So basically what happens is your false positives are coming down. So you're increasing your specificity. So only those who truly positive end up getting treatment. So downstream cost comes down if you're having a better, more robust tool for looking for TB. Now, this is the budget impact for immigrant population overall as an entire budget. And this is presented in millions. So when you do IGRA alone versus TST alone, at the end of 5 years, you're saving $1.63 million. But the cost of the test alone goes up. Okay, so I'll come to why that will happen. So same here. So when you're doing IGRA alone, the overall cost is 2.9 lakhs, but the cost of the test is 6. So how is that different? So what happens is IGRA is more expensive. You spend more on the test than your TST. So as over 5 years, more people come in, you have spent a lot more money to do the test. But downstream costs, so unnecessary extra X-rays, unnecessary treatment of TB, unnecessary hospitalization, all of that actually saves. So you are saving around 3 million. So overall cost of the test is 6 million, but you're saving around 3 million. So the additional extra impact on the budget works out to be around 2.9 million. So that's how you want to see whether the test is good, but is it actually how is it going to impact your budget? That's what you need to do. So that's what they have done. They've done it well. Now, WHO also says you need to do an uncertainty analysis, right? Because here, these are all imputational. You're like, you're assuming this will happen. So multiple assumptions are there. So what if you change these assumptions? So say suddenly Canada changes their immigrant policies, no more immigrants. So then you don't need to spend this much money on. So a lot of factors can change it, right? So you need to do some uncertainty analysis. So there are 3 analyses that the WHO recommends. One is the probabilistic sensitivity analysis. So that means you run like a simulation. So they've run 100,000 simulations. So each simulation, if you're changing, so you change sensitivity, you change specificity, you change different things, how does that affect the results? That actually requires some high-end technology. The other thing would be a one-way sensitivity analysis or a tornado plot. Now, WHO recommends that this is the bare minimum uncertainty analysis that needs to be done. So in this, what happens is you only change one aspect. So all the other parameters stay the same. You change only one aspect. How does that affect the result? I'll come to the tornado plot that they have done. Then you can do a scenario analysis. That means you do multiple scenarios. So if we change uptake, or if we change the population size, or if we change so in different scenarios, what would be the change, or what would be the outcomes? So that is strongly recommended, especially for the low middle income countries by WHO. So this is the tornado plot that they have given. So the tornado plot change in the incremental cost of IGRA alone versus TST alone in the immigrant population. So what this shows is, so this is the baseline cost. So say it's around, this is how much it costs. Now, if the specificity of IGRA among immigrants changes. So now say the specificity, right now they've pooled sensitivity around 0.98. Now say it becomes 1. So if you have a higher specificity, the cost actually comes down further. Whereas if the specificity were to come down, if it is only like say 70% specific or 50% specific or 30% specific, then actually the cost for doing that test goes up because you're getting false positive, then you're ending up treating. So that is what this plot shows. And so like that they've done for each thing. One other thing I want to highlight is if reactivation TB, so that means someone having latent TB, if the risk of them getting reactivated and becoming active increases, then your cost of doing the IGRA actually comes down significantly. So like that they've done for each of the things. So now they have only looked at it from a public payer perspective. They have not looked at it from a societal perspective at all. So now this is actually the European study on latent TB. So they have looked at productivity loss, travel costs, and for each step. So apart from screening and treatment, they've also looked at travel costs due to screening, travel costs due to TB treatment, all of that, productivity loss. So at each, so when you look at it from healthcare, we need to pay this much. But from a society perspective, that person is not going to the hospital. Test came back positive. Okay, they can't work. So all those things are also factors to be considered, which this study has not. The next domain is organizational aspect and implementation feasibility. So things that you need to look at is laboratory capacity, training requirements. So if you do a TST, you need to start doing TST for more people. You need to train more nurses. So resource constraint, implementation feasibility, number of visits, time required per staff. So there are a lot more aspects to it. So yes, IGRA is a good test. Let's start doing it. But when you actually start doing it, what are the implications for the system? That also needs to be looked at. So, but this study does not actually comment on most of these things. They just briefly mentioned that, oh, we need more tests. And right now, IGRA has been only done in one. But they have not actually sat and looked at it. So this is again from the European study. So they have actually looked at multiple. So there's a much more robust study. So they, we said TB treatment. The TB treatment is start consultation. So then you need to do an X-ray, the culture cost, the microscopy cost, the drug susceptibility testing. So, we know there's much more to it. So now if you suddenly start doing IGRA for everyone, you're getting these many tests positive. There's a lot of downstream costs also that you need to account for. And their flow diagram is also much more, this is a positive X-ray, then you do a smear, if smear negative. So there's many more aspects to it. Whereas this studies, they've done it in a very, so if say, for example, new scenario, test positive treatment. But before treatment, are you going to do a chest X-ray? Are you going to do a culture sensitivity? Are you going to check liver enzymes? They have not actually explicitly described that. Maybe it was part of the original studies, but they don't actually cover that in that much detail. So implementation aspects has not actually been considered in their study. So this is again the European study. So they mention implementation. Can it be integrated into health programs? How will you evaluate it? What are some organizational aspects that you need to look at? So this is done. So that is what you need to do to be a truly good health technology assessment. Next comes the ethical, social, and equity consideration. So there's something called the progress framework. So that is basically looking at a place of residence, your race, ethnicity, language, occupation, gender, religion, education, socioeconomic status, your support system, age, are you pregnant, are you incarcerated? So now these are all factors that make you, so like those who are being incarcerated might not be getting all the treatment or all the options. So equitable distribution is a major concern. So these are the people that you need to specifically consider when you're looking at a health technology assessment. So while the Canadian study, they mention it in their introduction, and they talk about the Progress Plus framework, and they briefly say that, okay, immigrants are at equitable this thing. There is language barrier, rural access. They don't actually cover it. They don't do a subgroup analysis. So whereas if you looked at the European study, they did migrants at entry, in the prison, homeless people. So they look at each of those subgroups, whereas the Canadian one does not do that. So they just give a sort of paragraph about it. Say there is some inequity, and they have again not looked at the individual payer cost. And the payers' lost wages travels are going to be the ones who are impacted the most, and that is the immigrants. Those are the people who are usually daily wage earners. Now there's something called ethical and social consideration. Again, they have not looked at it. So this is something that I thought of. Like, so what would be things that we need to think of? So are there harms from false negative, false positive? Is it are you forcefully screening? Is there discrimination towards refugees and migrants when you say you have to do it only in that population? What about stigma of TB? What happens to the test results? Are you maintaining privacy? So these are some ethical and social concerns. They have not addressed this. This is again the European study. They give for each column, they have social aspects and an ethical aspect. So that is what a good HTA should have. Then comes the stakeholder involvement. So WHO mentions there are 7 stakeholders that you need to look at. So you have patients, you have the providers, payers, purchasers, policymakers, product makers, and the public. So you should look at each person's perspective from a health technology assessment study. So now they've done like a purposive sampling. That means they've looked at people who are likely. So I know that Dr. Vignesh is doing TB screening. So I get in touch with him. So you purposely contact specific people. And then you do something called snowballing. So Dr. Vignesh mentions Dr. THAMBU is also interested in this. Then I go to Dr. THAMBU and talk to him. So that is a snowballing. So they have done that. And they have asked the stakeholders questions about feasibility of IGRA, access barriers, operational issues, system level implication. And the stakeholders they interviewed were clinicians, public health TB program staff, laboratory experts, implementation experts, policy managers, but they did not interview any patients. So what they said is that they put up posters and they got in touch with TB awareness and support groups to try and get patient recruitment. But finally, they didn't get any response from any of the patients. And they've mentioned that this is likely due to a language barrier. But that's something that they could have anticipated and tried to target those patients, which they've not done. So instead, they've just done an online survey of 53 health professionals to see what they think the patient's perspective would have been. And they've also looked at evidence from already published papers on patient preference and accessibility. So now this is not even a full qualitative studies. That means they've not done interview, focus group, thematic coding. They've just generally interviewed some people and highlighted some of the things that we said. So these are just some quotes. So on an average, it seems to be that the public, the players, so the clinicians, all of them felt that IGRA would be a better tool. It reduces the number of times that the patient should come and go. Okay. Then there's something called legal aspects. Again, this study does not address it. So some aspects that they need to consider. So like accreditation of a lab. So are there enough labs that have accreditation to upscale this? Scope of practice. So are the nurses, if they're wrong, what happens to them? Privacy laws, what happens to the results? Who's getting it? What about human rights? Is there any discrimination against immigrants, refugee happening? So immigration laws, so now, and employment. So there are rules that everyone who comes in, all healthcare workers should have this test. So have they accounted for all the legal aspects when they're looking at this IGRA test? So say the law for all employees, they have to have a TST. Then if you say only IGRA is done, then what happens to that group? So they have not actually looked at the legal aspects of this. So coming back to the European CoreNet model, have they looked at health problem and current use of technology? Yes. Have they described the technical characteristics? Yes. They didn't describe safety. Clinical effectiveness was looked at. Cost and economic effectiveness, they did do, but they didn't do their own economic analysis. They don't give you a pooled ICER. They have not looked at society perspective. Ethical analysis not done. Organizational aspect not looked at. Patient and societal perspective, they did do stakeholders, but the main thing, which is the patients, were not included, and legal aspects were not covered in this HTA. So this is actually called the international checklist for a HTA report. I'm not going to go to the whole thing, but they give you this final checklist. So whether they've done that. So list of all the authors identified, conflict of interest, summary in non-technical term. Yes, they do that. But what they don't do is they haven't got it externally reviewed. So one reason why they didn't do it is because they didn't do their own study. They've actually just pulled results from other things. So therefore, you don't necessarily need an external validation. But the budget analysis part was not externally validated. In terms of how, yes, they give you search strategy, the databases, year, all of that information is well specified. But they don't give you legal implication, ethical implication, social implication is not covered. And they give you what the finding of the assessment, conclusion, and suggestions are provided. So if you've concluded anything from this, HTA is essential, but it is not easy. It's a humongous, like a giant task, and cannot be done easily. It requires systematic reviews. It requires economic model. It requires stakeholder input, equity analysis, implementational consideration. So it needs a special team of clinicians, economists, epidemiologists, statisticians, public health experts. So this is not feasible for an individual clinician or even smaller hospitals to do. But WHO says that all countries should establish a dedicated HTA agency, and because it ensures transparent, evidence-informed, and effective health policy decision. And HTA, they've actually part of the universal health coverage. They think it's an important goal that they have set. People should develop a HTA agencies. And actually, India is one of the countries that does have a HTA. This is our HTA website, actually. This is our logo. And they have so far, we have 8 resource hubs, 20 resource center. Unfortunately, CMC is not one of them, but most of the other large institutes are. So far, they have 98 completed studies. So the way it goes through is like the topic is given by either the state or the central government. And they, like I said, you have to do priority setting. So they decide if that is a priority. And then they decide where. So the technical committee decides if this is a priority, and then which hub. So if it's like a Tamil Nadu based thing, then the Tamil Nadu Resource Center will be the one that does it. And these are some articles that they have actually published already. There's 98 of them. I've just taken the first few. And this is actually one sort of related to our TB topic. And they provide you the full article as well as this sort of summary statement that they give you. So this is a HTA looking at AI-assisted X-ray reading for TB. And they actually found that remember the ICER diagram that we showed? This is the willingness to pay threshold. So for the Genki AI model, it was increased cost, but better effectiveness and fell under the willingness to pay threshold. And for the Cure AI software, it actually was in the lower box. That means it was cost effective and better outcomes as well. So they have actually provided this for each of these studies. So coming back to our case scenario, should we start using IGRA for high-risk populations? So clinically, TST is shown to have better sensitivity specificity, and they have done a analysis, they've pooled all the reviews. So we can take that. Technical feasibility, yes, we do. CMC does have IGRA. We are able to do it. Cost effectiveness and budget, we cannot extrapolate their data. We would have to do an adoptive HTA. That means using our scenario, we would have to do that. And social, legal, ethical, and stakeholder aspect, they didn't do, and we would have to do it in our context. So you cannot take that HTA and start doing it here. Also, the WHO actually says IGRA is not for high prevalence states. IGRA is not the ideal tool. So I'd like to acknowledge Dr. THAMBU and Dr. Vignesh. Thank you.